right, we have about 20 minutes. The panel is open for discussion. I'd like to start. We have a question at the front.
Thank you very much for that presentation. That was awesome. Maybe CMS, I don't know anything about this, but maybe CMS...
can you state your name at the beginning?
Yes, my name's Sarah. I'm actually with Cook Medical.
Okay.
Maybe CMS is concerned about cost-prohibitive procedures versus data. When you talk about, you're right, there's more data for DCBs versus atherectomy right now, and maybe it's about, maybe they feel atherectomy is still cost-prohibitive, and that's why they're providing more reimbursement. I don't know. I just thought maybe the cost should enter into that understanding.
I would just say we need to try to get to the bottom of it. Some of us have contacts with CMS and interact with them in many ways, but as advocates for patients and your practices and as well as your companies, I think Mehdi's right. We have to try to advocate for what's right for patients, and I think by not reimbursing for a therapy that's being used more than most of us believe in, it's going to limit that use because there are people, and I'll blame hospital administrators for this, there are hospital administrators who cause us to not use things because of cost. Some of us are lucky we don't have those prohibitions, but I don't know if others on the panel think differently.
John, you want to make a comment? I think, No, I was going to, follow on that. The reality is that, I don't think CMS should make decisions. I don't think the cost of a device should supersede data. And we shouldn't allow CMS to do that, even if they want to do it. So, and I don't even agree that the cost is more. I mean, I think that, yes, you're right, the atherectomy devices are more expensive compared to DCB, but, the data is on the side of DCB. So I don't think even if CMS wants to do that, I think we have a duty to allow that if we believe the data is strong enough. John.
The Schuyler, separate question. Actually, I'm working with Manesh a little bit on this as well. But two questions. One is, can you comment on the role of cilostazol and impact on wound healing in diabetics? And the second question, can you talk about the interaction between DOACs and antiplatelets?
So I mean, the use of cilostazol is obviously old. When we looked at it in our meta-analyses and systematic reviews, we didn't really focus specifically. There weren't enough studies for subgroup analysis. I don't know, Matt, if you wanted to comment on that. Certainly there are small studies that show that cilostazol is effective, and why it's effective, I don't know.
Yeah, I don't think we know the mechanism, but the Japanese certainly have a lot more experience and much more routinely. Because they're limited, they don't have the technologies that we have. And there was a really nice review, Rosai Kansai Hospital and 4 other centers where they looked at cilostazol use in folks who had smart stents and really dramatically showed outcome benefit with cilostazol. We don't know the mechanism, but I truly believe that that's a low-hanging fruit and something we really should pursue as a society and looking into that.
To your second question, John, I think for DOACs, there is no question that there are going to be nice studies upcoming with multiple DOACs in big populations. Compass is a big population. Voyager is a nice size population. To my understanding, neither apixaban nor edoxaban have committed to doing big studies. Most of these are going to be strategy studies, as you saw with Compass. So it's going to be an antiplatelet plus a DOAC or one or the other. So I think those 3-arm or more approaches are going to be nice because most of the data for adding antiplatelets to oral anticoagulants have just resulted in bleeding, at least in the coronary population.
The other interesting thing about this is that, these studies, they keep focusing on the low-risk PAD patients. And the question is that, are you willing to take that risk of bleeding in a low-risk PAD patient for very small incremental, MACE? So I always struggle because, we need to understand the baseline characteristics of, Compass and other studies that are evaluating these DOACs. But, that's always the challenge, for me, because they're not studying CLI. They're not studying the kind of patients we're discussing in this session.
Before John comes back, I'm going to argue with you because no PAD patient is a low-risk patient. I understand
but
that
you saw Aaron Armstrong.
5.5% rate of cardiovascular death, MI, and stroke is a high risk. Our problem is that I agree with you. CLI patients are definitely higher risk, and we probably will provide a bigger benefit to those high-risk patients. Our biggest problem is that we can't get people to study the damn disease with a higher rate of readmissions and cardiovascular outcomes than heart failure.
Right, and one of the interesting things about the aspirin subgroups from Capri and then Charisma, the event rate for Capri in the aspirin subgroup was 5.8%. The event rate for Charisma 10 years later was 3.8%. So, there's a lot of other background therapy going on that reduced that event rate over those 10 years, and I'm sure we're going to continue to do that. But then there's data that shows how underrepresented and undertreated our PAD population is. So there's a lot of population health that we need to pursue in taking better care of these patients.
Yeah.
So I guess my follow-up is the two things I struggle with as a clinician after many years. And first of all, you have like the Vorapaxar and EPAD, both of which are positive trials, different agents, different mechanisms. They look pretty good, but when would I use those instead of typical dual antiplatelet, single antiplatelet? And the other arm is I get patients who have had history of venous thromboembolic events on oral anticoagulants. Now I do some endovascular therapy. Do I add an antiplatelet?
Yeah. So I think that leads to what I was hoping I could get the panel to do, and take a quick poll of what you do in standard patients. So if we can go this way to this way. So I have written down claudicants, you're not planning an intervention, they're relatively stable. How do you manage them? I'll start and then we'll come this way. So antiplatelet monotherapy currently.
Yeah, I do the same for claudicants.
Okay.
Yes, antiplatelet.
Okay.
Yeah, I'm the same for claudicants. I tend to leave people on aspirin. Part of me feels like I should switch them to Plavix with all the data we have, but for some reason I continue to use aspirin for critical ischemic. I'm more apt to keep them on dual antiplatelet therapy.
Aspirin for claudicants.
Yep. Aspirin and cilostazol, you're right, if they can tolerate it. Yeah. And so CLI. So CLI that either, none of them are going to be, or very few of them are going to not be intervened upon or at least looked at. For post-PVI patients, I'm dual antiplatelet therapy, and that's typically aspirin and clopidogrel unless they are on something else, John. And so if they're on a DOAC or something else, then often I'll do a short term of aspirin plus what they're on. But aspirin, clopidogrel, either surgically or PVI, but most of what I do is PVI.
That's my practice pattern as well. I think the bigger question is how long do you keep them on dual antiplatelet therapy after their intervention?
Yeah.
So aspirin and Plavix for a limited amount of time after the intervention.
3 to 6 months.
Between 3 and 6 months.
1 to 3 months.
No, 3 to 6.
12 to 15 months, right?
3 to 6. I mean, there's no reason.
So I would say, 3 to 6 for an uncomplicated. Now, most CLI is not uncomplicated, but if let's call it the popliteal that you open, that you get good flow and you have a TBI improvement, probably a limited time.
Yeah,
similar.
I think you have to weigh the risks of bleeding in the patient, and they are AFib and other reasons they're on these anticoagulants. If they're not on an anticoagulant, I'm more apt to leave them on dual antiplatelet long term and make a clinical event, have them come off of dual antiplatelet therapy.
I think I have influenced Matt too much. We work together. So I am also. So for CLI patients, I like to keep them on dual antiplatelet therapy. I think some of the work Aaron Armstrong has done supports that. So we typically leave them on dual antiplatelet therapy until the ulcer heals. At that moment, we then evaluate, risk benefit. If they can tolerate it, I just leave them on dual antiplatelet therapy. If there are issues and concerns, then I will take them off. Now, I don't know if your next question is going to be if they're anticoagulant. So are you going to that?
That was where we were going to go next,
Okay.
if that's all right.
Sorry.
So patient who comes in who has atrial fibrillation or a DVT or multiple DVTs who are on an oral anticoagulant, and they undergo, let's say, a FEM-POP intervention. We'll call it a PVI first, and then we maybe, Alik, you can talk to us about what you do after your vein or PTFE graft. I would say short term, often I'll do either aspirin or clopidogrel for somewhere around a month, and then I'll get them back, and they'll be on their oral anticoagulant starting back, and then I continue their oral anticoagulant after that. I have no idea, no data to support that. I'll say that up front.
Yeah, I agree. I think there's limited data, but for the majority of patients that we see that are not high bleeding risk, I do triple therapy for a month. And then
Triple for a month. Okay.
And then I put them back on aspirin and whatever anticoagulant.
And you do that because of your coronary work, or your comfort with the coronary work.
Correct.
Okay.
So in patients who are antiplatelet and anticoagulants, before open surgery, the anticoagulant is stopped.
Yeah.
And then restarted, depending on what the reason was for anticoagulant use, a week later.
A week later, okay.
Yeah, I like clopidogrel and whatever the anticoagulant is for those high-risk patients.
Okay.
Yep, I'm actually the same. I, typically stick. I do aspirin and Plavix. If they're on Coumadin, I do aspirin and Plavix until the INR is therapeutic, and then once the INR is therapeutic, I drop the aspirin.
So
if they're on a DOAC, then it's a little bit more challenging. I just tell them to take Plavix and DOAC.
Yeah. So it's you're using a WOS-like strategy.
Right.
So you're using more of a triple therapy. I don't know what I'm using. I'm marvelously confused. John,
I keep popping up, but these are real questions I have. I'm an experienced guy, so I'm hoping the questions other people have. So another scenario, recurrent failures. They either come back with thrombotic or restenotic failure over and over and over again despite dual antiplatelet therapy. Any switches?
I can tell you that until recently I didn't know how to spell Vorapaxar, but in those cases I may try to do that. I joke about spelling drugs, but I mean, sometimes in patients who are on dual antiplatelet aspirin clopidogrel, I'll add something like Vorapaxar because of the risk of hospitalization for acute limb ischemia. It's a modest improvement. The risk of bleeding doesn't increase, but this is a really high-risk patient population.
Yeah, I agree. Particularly in patients that have developed ALI after revascularization on dual platelet therapy, we've used Vorapaxar more frequently.
You just got to find it at pharmacies.
So I've never used Vorapaxar. In those patients, we start Coumadin.
Would you think, Alik, there's a role for an oral anticoagulant in those patients rather than warfarin? Or is your belief from with warfarin?
No, it's personal comfort. I think there probably is a role for it, and maybe I'm not doing it correctly. Maybe I should be using the other.
Oh, there's not data. We're not throwing barbs here. I was just curious if it was from data from before with warfarin.
No,
treatment.
not a lot of data.
Okay. Yeah. Anybody else?
I mean, we all agree that triple therapy, though, is probably too risky to keep them more than a month. Is that
Right.
That's generally our practice.
And do we agree that long-term with a NOAC is less risky than Coumadin, or no? I mean, all those trials basically showed less bleeding, and I mean,
Which trials are you talking about?
all the ones that
The
they took for
atrial fibrillation trials.
Right, exactly.
Yeah, so
Nothing in PAD.
I'll tell you that. I wrote the Aristotle PAD paper and the Rocket PAD paper. So both Riva and Apixaban, and the lack of clarity about which patients were included and what they had. All we knew was PAD, yes or no. That's it. And they all had atrial fibrillation. They're being treated with the standard therapeutic doses of oral anticoagulant in those studies. I would say we've got to get better at doing treatment strategies for these patients that are at high risk, because it's probably not that one treatment dose, a therapeutic dose for atrial fibrillation, is needed for vascular protection or prevention. It's my bias.
All right, I got one more question. So from your slide, do you think there's a therapeutic difference between a 75 aspirin and a 325 aspirin from the, I think I saw that in one of your slides that you're looking at.
Yeah, I mean, Capri was 325. Charisma and everything after has been, low dose. I frankly don't think there's any reason that a 325 provides more benefit. I just think the population was different. If you would have studied 325 versus Plavix in the Charisma population, it may have been a negative trial. I don't know. But I tend not to use a full-strength aspirin for my AFib patients or my patients with PAD or CAD. I tend to believe that the mechanism is irreversible inhibition and that low dose is sufficient. So.
The irony of all of this is that I'm helping lead the adaptable study through Picornet, which is aspirin low dose versus 325. And by the time it's done, it may be supplanted for secondary prevention if Riva is better or some other agent is better. But we're going to we've studied at this point about 5,000 patients with a history of CAD or cardiovascular disease, some of whom had PAD. Aspirin versus aspirin. It's not a very sexy trial, but it's going to hopefully answer the question in about 15,000 patients. But I don't know the answer.
But those are the exact trials we need to be doing. That we need to switch focus from this one-size-fits-all to really narrowing in on our,
Well, I can tell you at Duke University we've enrolled 550 patients in 7 months. We've never enrolled more than 220 patients in any randomized controlled trial, and the site payment is actually $285 per patient.
Yeah.
So you say, that's not a lot of money. It's a business to do research. Well, if you enroll 550 patients in pragmatic trials, that's a lot of money. Mm-hmm. And most of us have these patients. We just got to design the studies to answer the questions that are, in our brains.
And who's funding that?
So Picornet's funding it. They gave us $14 million for 20,000 patients to study the most basic cardiovascular question about aspirin. $14 million would have paid for like a tenth or not even that of Euclid. Same number of patients, a lot of the same data collection because we just transposed the Excel sheets to figure out what the case report form should be.
That's great.
Good session. Thanks so much for coming. Enjoy the rest of your weekend.